Thank you very much for this opportunity. Dr. Gubagminski, who is my mentor, unfortunately could not come. I'm sure you'd have much better talk from her, but myself and Gina, we are here on behalf of her, and I'm going to show background on JakSTAT, JAK inhibitors, and some data from the lab, as well, and Gina is going to show the results from the study that she conducts at the NIH. It's very difficult to treat, to decide on a treatment for the autoinflammatory disease because the clinical phenotype don't let us choose a targeted therapy because there are no established clinical criteria for most of the diseases, the majority of them. And then, and also there are not specific autoantibodies such as in the autoimmune diseases that have which have the clinical criteria, the classification criteria, and autoantibodies in most of them. So we need genetics. Nowadays, it's been easier with the next generation sequencing techniques. We need immunophenotyping to understand better the mechanism, and it's also very important to evaluate organ inflammation through histopathology evaluation. And also imaging, but especially histopathology. So I'm going to give you an overview of the JAK inhibitors and also of the Janus kinases. This pathway, JakSTAT pathway, is very important in human disease, and currently, there are currently approved JAK inhibitors for the treatment of myelofibrosis and polycythemia vera, which is ruxolitinib that Kim Nichols just talked about, and also tofacitinib, which is approved for rheumatoid arthritis. Yeah, I'm going to skip that and just say that the human kinome, which is the group of several kinases that we have, it's composed of 518 protein kinases. And the Janus kinases are tyrosine kinases of one of these 30 families of tyrosine kinases that, These are 4 Janus kinases: JAK1, JAK2, JAK3, and TYK2. First, TYK2 was the first JAK to be identified, and then in 1991, JAK1 and 2 were also identified. And then initially the name was just another kinase, that's why it's JAK, because there's only 3 at that point, in the middle of so many other tyrosine kinases and other kinases as well. But then, after their role was known to be so important, so the name was changed for Janus kinases. Kim Nichols also showed this picture here in the introductory slide for her. This is a god of beginnings and endings, a Roman god with 2 faces. So because the Janus kinases always have the 2 faces here, the 2 kinase and the pseudokinase, which is a regulatory domain. And they are very important for phosphorylating all the molecules, including themselves. And in 1994, Dr. John O'Shea group identified JAK3. So the JAKs are non-receptor or an intracellular molecule. Oh, sorry. Yeah. Are non-receptor intracellular molecules that they mediate the signaling of several cytokines depending on the receptor in which they are bound here. So, for example, I'm going to talk about the type 1 interferonopathies. So, interferon alpha and beta signals through the interferon receptor through JAK1 and TYK2. And this will lead to antiviral inflammation, to tumor general inflammatory response. So the role of the JAK inhibitors, of the Janus kinases is very broad. It will depend on the receptor in which they are ligated and also on the cytokine that is engaging on the receptor. And it's important to know also that the JAKs always act on pairs. They are always together. So the mechanism, very briefly, Kim also showed that. I'm just review it. It's very interesting, actually. So when the cytokine engages the receptor, the JAKs get activated and they phosphorylate themselves and also the receptor, the intracellular tail of the receptor, generating a docking site for the STAT. The STATs get phosphorylated and then they dimerize and go to the nucleus to induce gene transcription, because the STATs are transcription factor. That's also why it's more difficult to generate targets, therapies targeting STATs, because it's a transcription factor. So several of these targets here were mentioned today. These are mainly monoclonal antibodies or antagonists of receptor or soluble receptor, IOH binding protein, interferon gamma, anti-interferon gamma, also antibody. And these are all, are all used in autoimmune diseases, and many were mentioned today. The JAK inhibitors, they are very different because they are small molecules. These are not small molecules. So they have to engage with, they have to block the ATP binding site that I showed you in the JAK, in the Janus kinase, and then it will inhibit the phosphorylation of the downstream kinases and other molecules. So, as I said, there are three are more studied JAK inhibitors. First is ruxolitinib, which is approved, as I said, for myelofibrosis and polycythemia vera. Tofacitinib, approved for rheumatoid arthritis, and also with several trials, at least 2 trials in juvenile idiopathic arthritis, and baricitinib, which is the drug that Gina will talk about later. In regards to the specificity and also to the minimum concentration, inhibitory concentration for the JAK inhibitors, you can see that they have different specificities to the JAKs, to the tyrosine kinases. Ruxolitinib and baricitinib are similar because they block much more JAK1, JAK2, in comparison with JAK1 and JAK3, whereas tofacitinib really blocks JAK3 very selectively, much more than JAK1 and also JAK2, and almost doesn't affect TYK2. And just the approved drugs and the several JAK inhibitors also there are on study, including the baricitinib in autoinflammatory disease, which Gina is going to show. In regards to the results in the treatment of RA, comparing tofacitinib and baricitinib, they were actually very similar in regards to the ACR responses. They were very comparable. Tofacitinib has several studies going on still, including the one that I just said for 2 studies recruiting for JIA as well. And in regards to the side effects, I think I'll let Gina talk about the baricitinib ones. And now about the non-approved uses for JAK inhibitors. First of them, it's for alopecia areata. It was in the news as a potential drug to treat baldness also. So this is a study in this study. This is a patient in the study that Gina is conducting with Dr. Gobakmensky, and incidentally, they observed that this patient had alopecia area here, which resolved after treatment with baricitinib. This is also observed with ruxolitinib in other studies. In regards to vitiligo, same thing. These 2 pictures here are treatment with tofacitinib with improvement of the lesions, and also an improvement of vitiligo lesions was observed with ruxolitinib as well in a case report. So in regards to the type 1 interferonopathies, we are very interested on those. Here are just some examples of the monogenic ones, such as candle, which can be digenic, but Gina is going to, that's, most of the patients in the study have candle syndrome, and SAVI, which is patients, which is an interferonopathy caused by patients with gain-of-function mutations in STING, stimulator of interferon genes, and then Aicardi-Goutieres syndrome and SPANC-GI. We observed that, it's also reported that these patients may have several similarities. For example, basal ganglion calcifications and peripheral calcifications, neutrophilic dermatosis, panicularis, and then some of them can have a panicularis or levator reticularis. Interstitial lung disease is also, can also be observed in these patients. And we've been using the interferon scores by nanostring technique in peripheral blood from blood extracted with packaging tubes to determine if a patient has a type 1 interferon signature or not. We are still evaluating the positive predictive value and negative predictive value of this test, and it's not a biomarker, but it's just a tentative to understand better some patients in whom we cannot find a genetic diagnosis, which is unfortunately common. So, for instance, we always compare some other patients. We evaluated 52 patients, and 26 of them had an increase, had a high interferon score, whereas 55 patients, 25 had a low interferon score. This is very similar. These patients have a very similar interferon score to patients with the type 1 interferonopathies, monogenic interferonopathies, Kendall, here in blue, and SAVI, here in green. And then much higher than in healthy controls and in the IOA-mediated disease, NOMID. So, and as you can see here in these patients, sometimes we are able to identify a genetic cause that has already been described in the literature, but here, in some of them, we have either known genes, or we unfortunately didn't find any specific, any genetic cause for this gene. I'm almost done. I just introduced Gina now. So for Kendall, after the discovery of Kendall in 2000, genes of mutations in genes that cause Kendall, it was not possible only by the genetic defect to know which drug could be used for Kendall. So we had to evaluate the immunophenotyping through IP10 zero levels and observing that Kendall patients have high levels of IP10, and as well as interferon score, also very high in Kendall patients in comparison with healthy controls. Before actually the interferon score, we also did RNA sequencing on Kendall patients, and we observed a high expression, upregulation of type 1 interferon inducible genes in comparison with the IOA-mediated disease and with healthy controls. So this led to us to hypothesize that because the immunoproteasome, where the mutations in Kendall happen, it's a multiprotein complex that is important for the degradation of polyglucinated proteins. If these proteins don't get degraded, there will be increased intracellular stress, and this somehow could lead to increased type 1 interferon, which will engage to the interferon receptors and lead to activation of Jak-STAT pathway and the amplification loop. So we hypothesized that maybe blocking JAKs could be helpful for the treatment of these patients. So now Gina is going to talk about the clinical response of Kendall and Sav.